the sessions. So good evening and a warm welcome to the eminent speakers and enthusiastic participants for the webinar on rare disease in public health and Indian context, organized by DST-CPR IISc in partnership with Ashoka University. I'm Dr. Mahua Chakrabarti Chaudhary, a STI Policy Fellow at the DST Center for Policy Research, Indian Institute of Science, Bangalore. I'm an honorary associate at the Institute of Public Health and a member of the WHO Collaborative Network for Rare Diseases as one of the India representatives. At DST-CPR, my work is focused on understanding the rare disease landscape in India and finding possible policy interventions. We have been presenting interesting discussions on Rare Diseases Month, and this year in partnership with Ashoka University, with eminent scientists and rare disease advocate Dr. Sudha Bhattacharya and Dr. Alok Bhattacharya, and eminent scientist Professor Shashidhara, we are organizing a webinar series, and today is the first session on the very important topic, equity in representation of rare diseases in public health agenda. Rare diseases are the ones that affect a small fraction of population individually, but collectively it affects a large population. And in India, it is expected to affect 72 to 96 million people. However, despite these big numbers, until recently, rare diseases have not been showcased in any public health agenda of the country. 2021 has been a landmark year for rare diseases as India got its first revised rare disease policy, and the first resolution for rare diseases was also adopted at the United Nations. At CPR, we are exploring the potential of existing policies and programs to cater to rare disease patients. In our recent publication, which came out this month in the Orphan Journal for Rare Diseases, we explored the potential of National Health Mission in integrating rare disease management. Taking this initiative forward, in today's meeting, we have leading experts in the country to talk about the lack of representation of rare diseases in public health agenda, and we will try to explore ways to address some of the gaps. So without much ado, I will request my colleague, Dr. Pragya, to start the session. Over to you, Pragya.
Thank you, Mahua, for that wonderful introduction. I am Dr. Prashant Srinivas, and I'm a senior associate at DST-CPR IISc Bangalore. And I, along with Dr. Mahua, work on how to extend public health services to rare diseases. What policy interventions can we look at? And for today, I would like to start the session, and for that, I would like to invite Professor Shashidhara to give the welcome address. He has a very long and remarkable career, and his list of accomplishments is way too long for me to list on everything here. But currently, he's working at Ashoka University as Professor and Dean of Research. So without further ado, I would now like to request Professor Shashidhara to give the welcome address.
Thank you very much. Good afternoon to all of you. It's a pleasure to be here today. I'm representing Ashoka University, which is one of the hosts of this particular meeting. So before we talk about rare diseases, I just want to touch a little bit about the policy related one. So the DST, I'm a big fan of DST's Science and Technology Policy Fellow Scheme, and it has really building the capacity for the country in this area, and particularly under the leadership of Akhilesh Gupta. And among the many initiatives of DST in the area of science and technology innovation policy is, other than the postdoctoral fellows, also the setting up of centers. And one of the first such centers is in Indian Institute of Science, Bangalore, which again has pioneered many policy briefs on diverse topics, and it's a privilege to be associated with both DST and DST-CPR IISc to host this event. And when we talk about science and technology innovation policy, we always use the standard statement that all policies, particularly public health policy or public policies, should be data-driven and science-based or evidence-based. Right? And particularly when it comes to the rare diseases, there's always a problem of where is the data, right? And how much is the problem is this problem and how to even frame a policy on rare diseases. And many people, particularly Professor Alok Bhattacharya and many of his colleagues, have contributed a lot to understand the scale of the problem. And many times the word rare disease itself is sort of goes against any public policy agenda, is simply because it's considered as rare diseases. And when you start actually looking at the data, and collect and look at the data, then you realize what is the health burden at the public health level because of the rare disease in this country. Right? So in that way, now we have started realizing the burden of rare disease in this country, all over the world, and most, in Indian context, in a country of 1.5 billion, is extreme, diversity both at the levels of genetics and the socio-economic and geoclimatic conditions. So considering this, obviously, rare diseases should be on the top of the public health agenda. And because of it's still not understood much, the causality of many of the rare diseases. Obviously, once you don't know the cause of the rare disease, which particular genetic lesions and so forth, it's, we also do not have an appropriate treatment for rare diseases. So that means there's some big need to research on developing new therapeutics. And all of these things require that, the rare diseases had to be studied at a scale which has to be unprecedented, considering how much work has been done so far in the last few decades. The next 10 years, we should have really, an agenda where the rare disease should be at one of the major priorities. And you also have this particular conference or meeting is divided into two major sessions. One is to equity and another is the registry. Both are interlinked. Unless we have the proper registry and maintained and analyzed, we wouldn't know what's the scale of the problem, how much inequality exists in understanding and treating this disease, and what are the, how to bring in equity in public health to rare diseases as against any other disease in the country. It's about giving equity to rare disease itself. And the second is, among the rare diseases also, some rare diseases are given more importance compared to others without even understanding, the scale of the problem. Many times it's simply because some diseases are well understood, easy to study, easy to develop the therapeutics, or maybe there are more, pronounced voice in favor of one such kind of diseases simply because of a variety of historical reasons. Many other diseases may be, neglected. I think this particular meeting is envisaged to address some of these issues and come out with a policy on rare diseases for India for the next 1 decade, which is really critical. And the current pandemic has also emphasized the importance of public health, and hopefully there is some traction and momentum built in, and that can be used to promote research on rare diseases and developing new public health policies. So with this opening remarks, I welcome you all on behalf of our organizers, and over to you back. I don't know who is organizing this. Anjali?
Okay.
And Pragya. Yeah.
Thank you, Professor Shashidhara. Thank you for that welcome note. Now I will.
Your microphone has some problem. I think it's a lot of echo.
Let me just.
Maybe while hello, while Pragya fixes her microphone, I'll just take the opportunity to welcome, thank Professor Shashidhara for the wonderful welcome note and setting the tone. And I will welcome Dr. Jyotsna Dhawan to give the keynote address. So Dr. Jyotsna Dhawan is the CEO of DBT Wellcome Trust India Alliance. She has over 25 years of experience in research leadership at the Center of Cellular and Molecular Biology, Hyderabad. Dr. Dhawan was also involved in the establishment of DBT's Institute for Stem Cell Science and Regenerative Medicine in Bangalore in 2009. Dr. Dhawan has been the president of Indian Society for Cell Biology and the Indian Society of Developmental Biologists, and was elected as a fellow of the Indian National Science Academy in 2019. We are very fortunate to have you here to give the keynote address. So, ma'am, the stage is yours.
Thank you, Mahua, and thank you, Shashi, and all colleagues for organizing this wonderful session. It's really a privilege to be here with you. There's so much that needs to be done in this arena, and bringing all the stakeholders together in a forum like this is a really important step. So I'm going to start sharing my slides, if I may. Is it visible?
Yeah, now we can see.
Okay.
Yeah, full screen mode.
Great. Am I in full screen mode? Okay, good. So is there a network problem?
We can see it in slide mode. It's perfectly fine, ma'am.
Okay, fine. Sorry for that little technical glitch. Again, just want to thank everyone here for giving me the honor of giving this lecture. It's actually been an important thing for me to go back and look at the issue of rare diseases because as a basic cell and developmental biologist, one's motivation for much of one's work comes from trying to have an impact on disease, and but often one doesn't get there. And understanding the scale of the problem at a human level is something quite different from understanding the scale of the problem at the level of cells and molecules. And I want to give our audience a little flavor of that. So what I'm going to talk about today is really a bit about the biology of rare diseases and the importance of active patient participation being the key to discovery of new therapeutic avenues. And right on the bottom of my slide, you'll see a number of organizations that are focused on rare diseases as a cohort, or more specifically on the myopathies, which are close to my heart. And this is not to say that there aren't other organizations. I'm sure there are, and that they will forgive me for not having had the time to pull the slides together in a fashion that represents them. But I know there are others out there. So as was pointed out in the initial talk, I mean, rare diseases are really very many in number, but they affect a large number of people as well. And although there are, over 7,000 different rare diseases worldwide, about 3 in 4, 75% of them, of these rare diseases, are genetic in origin. So essentially understanding the genetic basis of the disease is the path to its treatment. Rare diseases in India, the recent national Indian policy for rare diseases has officially recognized only about 450. So there clearly is scope for a greater recognition of different types of diseases. And as someone pointed out in the earlier comments, there are 70 to 90 million patients in India. So this is not a small number. So collectively, they represent a very large number of people who are living with disability and disease, and often without hope for a treatment. So it's really critical that we come together to do something about this. Just to point out, some of these things are self-evident, but it's worth setting the framework for the discussion today. And that is that a fundamental challenge in research and development for many of these diseases is that there's little known relatively about the pathophysiology or the natural history of many of these diseases. They're difficult to work on, often because the patient pool for any individual disease in one location may be quite small, which means that there's inadequate clinical experience in any one center. So clinical explanations for these rare diseases might be either skewed or partial. And very often, these rare diseases are chronic. So long-term follow-up is particularly important, but very often difficult to do. Patients have little access. So there's less than ideal published data on long-term treatment and a poor characterization over the life history of the disease. So there are some particular challenges faced by the rare disease community in India. And that has to do with the lack of public awareness about these rare diseases, which is compounded by our social factors, which lead to endogamy or consanguineous marriages. Often there's lack of specific education among the medical community. And there are very few diagnostic centers in the country. And these diagnostics are very expensive and they take a long time. So the very few available orphan drugs are prohibitively expensive. They're not made in India for the most part. And access issues are compounded by lack of health insurance. I already spoke about the fact that there's insufficient research in rare diseases, partially because of lack of infrastructure and funding. And patients lack access to clinical trials, as most of them are occurring outside of India. And we really need, I think, to improve the collaboration among stakeholders within India and with global engagement. So I think it's very clear that rare diseases are a global health problem. So the solution also needs to be global. And that means that we need to work towards equity for people living with a rare disease. Towards that end, as you know, the Rare Disease Day is on 28th February, and this has been spearheaded by the NIH and with many stakeholders globally. And these cross-border collaborations are truly vital to accelerate access to life-saving therapies for rare diseases, or even towards the hope towards life-saving therapies. So I'm going to give you a cell and developmental biologist's perspective, and I'm going to show you here a picture of an iconic developmental biologist, Louis Wolpert, who said that it's not birth, marriage, or death, but gastrulation, which is truly the most important time in your life. Okay, so gastrulation for the lay people here is a key event in the early life of an embryo when it's only a few cells big, and during which time cell division, cell movement, and cell specialization in this early little ball of cells gives rise to the embryo proper. And it's here that we understand most critically how important genes are when they're controlling development, because as you know, many genes go awry in developmental programs that lead to rare diseases. So I want to shout out here for a wonderful blog that was written by Jyotsna Dhawan, who works on rare diseases by using the zebrafish as a genetic model. And what she wrote about was the obstacle course to being. And you know, this might seem like a strange thing for a scientist to be saying how miraculous it is that normal births actually occur. And the fact is, we have to think about the sort of bell curve of normalcy in genetics and the impact of very small changes in mutations, which lead to moving individuals outside of this bell curve, where you have a disease causing mutation, which leads to a single defect, which then has multiplicative effects over developmental time courses to lead to defects that cause major problems in either a single organ system or multiple organ systems. So as you can see, if you just think about the continuum of life as being a network, which is integrating different molecules which are controlled by genes, which integrate into cells and have to work together to make networks. These networks essentially underlie an organism. Organisms themselves form networks which create ecosystems and society. So what you're looking at is defects and mutations that take place at the level of molecules and genes, which have these multiplicative effects all the way up to give you the disease phenotype, which has a major impact on society. So I'm going to spend a little bit of time focusing on the neuromuscular diseases because those are the ones that are closest to my understanding and to my work. As you know, the neuromuscular diseases themselves, and this we're just talking about, two organ systems compared to the rest of the body where there are so many other things. We talked about the fact that there are 7,000 rare diseases. But if you look at the neuromuscular diseases, even they are so variable. They vary in their pattern of inheritance, the origin of the genetic mutation, their incidence, the symptoms, the age of onset, and their rates of progressions and prognosis. So on the left, you just have a list, a very partial list of some of the important neuromuscular disorders. But what you can see immediately when you think about the musculoskeletal system, you have a very large and distributed therapeutic target. So any therapeutic avenue that you think of has to be something that is going to affect all of these cells and muscles. So it's a difficult thing to do. This means that you have to have a systemic therapy that works across the body. Now I'm just going to focus a little bit on the muscular dystrophies. There are many kinds, as I suggested earlier. And what happens in muscular dystrophies is that you go from a normal complement of muscle to atrophy and loss of muscle, as you can see in the disease condition. Now, if you look at the level of the cell, and this I'm showing you are cross sections of muscle stained to show the protein which is defective in some of these muscle diseases, you can see that the pathology consists of a very aberrant type of histological distribution of the muscle cells and a lot of inflammation. And mutations in muscle proteins underlie these muscle diseases. And one of the important ones is the dystrophin-dystroglycan complex. I don't want to get too full of jargon, but I do want to just point out that a single mutation in a single protein which lies at the surface of the cell and connects the nucleus to the exterior of the cell via the cellular skeleton is the cause for this disease. And when you have different types of mutations in different members of this whole complex, it leads to very different kinds of myopathies, which affect different groups of muscle. So just from a single gene, when you have different mutations, you affect different muscles differently. And when you have mutations in different members of this whole complex, you have very different types of diseases. So, this increases the complexity of what you're trying to therapeutically correct. So now normal adult skeletal muscle can repair itself by regenerating. And what I'm showing you here is simply what happens to a muscle after it gets injured and has a cleanup process that the inflammatory system and the muscle stem cells perform and then regenerate perfectly well. But a diseased muscle cannot sustain a repair response and it degenerates, leading to pain and disease. Now, in skeletal muscle, you have stem cells which are available for normally doing this purpose. And these stem cells actually normally sleep in the adult muscle, but are woken up by damage and repair the muscle and then go back to sleep. So in other words, waking them up is important for repairing the damaged muscle, but going back to sleep is also critical for making new stem cells. So returning to this dormancy creates the capacity for future unpredictable damage. So understanding even dormancy is an important aspect of basic muscle biology, and it's something that my lab has been interested in for many years. But what are the outstanding issues with the potential for stem cell transplantation for the muscular dystrophies or other myopathies? So as I referred to earlier, skeletal muscle represents a very large and distributed target. So you need very large numbers of stem cells. So it's not a very practical approach with our current knowledge. Now, we also know that most of these inherited myopathies have very few therapeutic avenues available because they are degenerative, they're progressive, and you get irretrievable pathophysiology. So can we think of ways to prevent degeneration rather than fix it once it's happened? For that to happen, we need to understand the normal homeostatic repair and regeneration at a molecular and cellular level. So there are many paths to intervention, potential ones. You can modulate stem cells in situ by systemic signals directly using little packages like exosomes, or by metabolic programming or small molecules which are targeted to these skeletal muscle cells, or by targeted RNA molecules or gene editing. And, you know, speaking of which, I mean, in the middle of this pandemic, one of the sort of great benefits, if we can say, to have arisen out of the pandemic is the absolute supremacy of mRNA technology. And, you know, something that has been worked on for 30 years suddenly found its day because of the absolute urgency for mRNA-based vaccines. And use of mRNA technology may well be one of the key hopes for many of these rare diseases because they are tunable and they can be used to deliver even gene editing molecules. So this is still a very nascent area of research, but I think is going to be something that offers great hope for the targeting of different types of rare diseases. So the long-term goal of these kinds of studies, I think, is to use the endogenous regulatory pathways and networks in patients to reveal pathways and molecules that may actually permit exogenous control either of stem cells or prevention of degeneration and the pathophysiology. So I want to spend a couple of minutes highlighting new research in muscular dystrophy in India. And this, I'm highlighting work from Dr. Akashubra Ghosh at the GROW lab in the Narayana, Nethralaya. My network was unstable. Am I audible?
Yes, Jyotsna, I can.
Yes, ma'am.
Okay.
Hear you.
Yeah, okay. Sorry for the interruption, but just want to point out that Aka is working on a number of different types of rare diseases using the approach of actually creating a wonderful platform for being able to make genetic therapies available. And that is, they may target everything from retinal diseases to muscular diseases using adeno-associated viruses. So the AAV lab that he has established at Narayana is really now moving to scale, and it's a remarkable thing that this is happening. He's generated a system of AAV vectors, which he's developed, and he's expanding these into plug and play delivery systems and using them in animal models with a substantial degree of success. And what he's doing is creating a production facility, which is now operational, and so that he can make sufficient amounts of these vectors to be able to start potential clinical trials. So these are just some of the technical aspects of the AAV vectors that he's been able to develop. And what he's showing you here is the sort of jigsaw puzzle plug and play type of technology that he's hoping to generate. And over here is just a single result that he's shown using a situation where he's injected the animals in a mouse model of muscular dystrophy, the MDX mouse, which lacks dystrophin, and where he's showing the widespread expression of dystrophin with a single injection of this AAV vector carrying a mini dystrophin. He's also using adeno-associated viruses for transducing retinal layers in the mouse. And what I'm showing you here is his efforts at moving towards a dedicated clinical grade gene therapy production facility at Narayana. So just want to get back to the broader situation, which is that to point out that patients and their families are critical in the progress towards new discoveries, both from the perspective of advocating for policies that enable government and NGOs to focus on the real problems and create mechanisms for funding, and also being active participants in discovery research, not just a passive recipient of ideas that are developed for academic interest or without an understanding of the lived experiences of patients. So here I'm showing you Sanjana Goel, who's the founder of the IAMD. She is herself an LGMD patient. She's founded this wonderful facility in Solan in Himachal Pradesh. And I'm showing you pictures here of Sanjana with my colleague from CCMB, Dr. Chandak, who runs a camp there every year for genetic diagnosis and palliative care of many of these muscular dystrophy patients, of which there are a very large number in India. So it's very clear that both basic and clinical research in rare diseases has to be collaborative and include longitudinal studies. We need to train investigators in clinical research. We have to have pilot and demonstration projects. And we also need to make sure that patients, physicians, and the public has open access to information related to rare diseases. We need a greater patient involvement in drug development. We need natural history registries. We need targeted therapies, as well as we need targeted incentives for rare disease drug development, which means that our pharmaceutical and biotech industry needs to get involved in a very real way. So I'll stop there, and I'll give very special thanks to Nisha Venugopal from Indo-US Rare, who helped me in the presentation and pulling together much of the information in these slides, and Dr. Arka Shubhra Ghosh, who was kind enough to share with me some of his work. And I'll also give a shout out to the India Alliance Fellowship and Grant awardees in rare diseases, of which we have several. And this, in particular, the Center for Rare Disease Diagnosis funded by the India Alliance. To end with thanks to my lab and to acknowledge all the sources of funding that have helped me in my own academic journey. I'm now, of course, no longer doing that much active research. And I also want to thank collaborators like Anna from the University of Paris Diderot and Alok Bhattacharya. So thank you very much. I'm happy to take any questions.
So I think Mahua.
Yeah, Anjali, please take over and start the session to the panelists. Thank you, Dr. Jyotsna, for delivering a wonderful start to the session and setting up the keynote address. Thank you, ma'am, for joining us. I give it over to Dr. Anjali to take it over from here.
Thanks, Mahua, and good afternoon, everyone. First of all, thank you, Dr. Jyotsna. I think you have already set the context for the panel discussion in such a wonderful way. So thank you so much. May I please quickly introduce myself? I am Anjali Taneja. I'm a policy scientist, and I've been leading science policy initiatives at Ashoka University. Ashoka University is one of the leading arts and sciences universities and focuses a lot on interdisciplinary research and advanced research and development across a lot of fields which are very new to India and coming up in a big way. So happy to be here with all of you and taking the discussion forward to the next session. So now we have the panel discussion, and we have 4 eminent panelists with us, speakers. Just to quickly give an overview of how we will carry out this session.
It will be divided into 3 parts. So the first session would be addressed by each of the panelists for around 8 to 10 minutes. Second part of the session would be an open floor discussions on the basis among the panelists on the basis of what was discussed in the first session, and accordingly we can discuss how we can take it forward in terms of a roadmap on equity of rare diseases in public health agenda. And the last session would be the Q&A, where we would request the audience. I think a lot of questions have already been pouring in for Dr. Jyotsna. So I think the audience doesn't want to let you go that easily. So most of the questions we request the audience to actually put in the Q&A panel, and we will take it at the end. And of course, if it is addressed to a specific panelist, maybe you can also mention to whom it is addressed in your question, and we can take it from there. So without wasting any more time, we'll move on to the first part of the session, where we will have addresses by the panelists. And please allow me to welcome very accomplished and esteemed panelists today, Dr. Prashant Srinivas, Dr. Arun Singh, Dr. Ratna Devi, and Dr. Narendra. So taking on the first panelist for the discussion is Dr. Prashant Srinivas. Dr. Prashant Srinivas is the Assistant Director Research and leads the Health Equity Cluster at the Institute of Public Health, Bangalore, and DBT Wellcome Trust India Alliance Intermediate Fellow. He has worked at the intersections of healthcare and health systems with ecological and social systems, with particular focus on health inequities and social determinants of health. His work critically examines the apparently transformative dimensions of technological solutions to health inequities with regard to addressing fundamental issues of social inequity, exclusion, and governance. Dr. Prashant, the floor is yours.
Thank you. Thank you very much, Dr. Taneja. And I request, if possible, if my slides can be shared. If not, I can also share them. So if one of you could let me know. Thank you very much. And over the next 10 minutes, I think what I will attempt to do is come from a perspective of a public health researcher, somebody who enters the rare disease debate, rare disease dialogue from the perspective of public and population health. And a bit later, I'll come back to this tension between the idea of achieving public health goals on one hand and securing access to rare disease treatment for everyone on the other. I'm just pausing to check if the slides are possible to be shared.
Yeah,
if not, I can also share them. Sure.
Yeah. So,
sure.
Yes.
So my name is Prashant, and I'm speaking to you all from BRT Tiger Reserve. It's a public health research field station that the Institute of Public Health Bangalore set up several years back. And of course, it's really the amazing improvements in technology that today allow me to be able to do clinical and research work in a small setting, but also participate in these kind of events from such a small place. So on one hand, the power of technology, the power of knowledge, and the power of innovation, I think is something that is also an important sort of context in the rare disease landscape as well, because there's so much of research and innovation happening in the rare disease space. But on the other hand, when we talk of equity, what really creates this tension I was talking about earlier is how do we secure these power of knowledge, power of technology, and power of innovation to everyone? Because we are talking here. Yeah, thanks. Can we not move the slides? Sorry. Yeah. So because we are talking here of being able to ensure health for all, that's one of the important elements of equity. If we go to the next slide, I think in the initial piece, the 2021 achievement of the Government of India notifying a national policy on rare disease, I think was noted, and I think that's very important. And as you can see in point number 5, there is this notion of equity already included in the policy, which is important and commendable. I think, however, we can try and examine what does this equity mean when it is stated in a policy document. what does it mean in terms of practice and implementation, and how do we integrate it meaningfully into our public health policies and practice? Here on the left, you can see the tension I was talking about earlier. Many of us in public health schools are taught about how we must choose modalities which secure greatest good for the greatest number, right? And this is always in tension with the fact that health is a human right. Every single person who has an illness or a disorder, and if there exists a treatment or a therapeutic or a diagnostic that can change their life situation, they ought to be able to access it, because health is a human right. And one of the ways for me, and I'll try to resolve this tension and try to dispel this myth that public health and public health policies are sometimes in opposition to rare disease work, which is, I think, not the case. And one of the ways in which we can do that is through examining the equity element, which we will do. So with rare disease, one is with India, the numbers, and two is the neglect. And the neglect is not only of the specific diseases, the neglect is also of the idea of rare disease itself in the policy and practice scenario. And third is, I think, the understanding that equity is typically constructed as a rich-poor divide. And you can see that also in the national policy on rare diseases, where I've underlined where equity is immediately addressed as an affordability issue. And we must keep it in mind. Equity is far more than a rich-poor divide or a matter of affording therapeutics. Next slide, please. So one of the ways to understand equity is to immediately look at what the World Health Organization and various other people call the social determinants of health. And we can move to the next slide. And the primary idea of social determinants of health in the Indian scenario is that health status and health care are already patterned. They are unfairly distributed. So what does that mean? It means that ill health is not randomly distributed. Ill health tends to accumulate much more in people who are already having a social disadvantage of one kind or another. So this is something that we comprehensively synthesize in a recent book on health inequities in India, where there is, of course, a chapter on health inequities by socioeconomic position, but you also have health inequities which gather unfairly by caste, by gender, by disability, and various other social vulnerabilities. And these vary by state, by region, by district. So in different districts, different regions, different states, new and different kinds of inequities emerge, which straight away positions the problem of social inequalities as a governance issue, which needs to be tackled in a much more decentralized way than we are able to address at a national level. Next slide, please. So I will not spend too much time on this. Those of us in public health are very familiar with the pathways through which this unfairness tends to accumulate, and this is what is called as a social determinants of health framework. And the pathway through which this accumulates is the fact that access to resources, access to social networks tend to shape how people behave, as much as individual choice might also play a part. And the reason I bring this up, especially in the rare disease dialogue, is because we often tend to locate individual choice or individual behavior as a primary reason or primary locus for action on social determinants, whereas the body of literature shows us that the locus of action also has to be at systems, governance, policies, social networks, and power. Ultimately, who has the power to make a change, and how is this kind of power being used? That way. Next slide, please. So just to give a practical scenario for this, when we talk of access to technologies, because ultimately access to therapeutics, access to diagnostics are an issue of access to technology and innovation. And even if you see something like type 1 diabetes among the Adiwaji communities that we work here, access to insulin is still a problem. Take the example of access, and insulin, as you know, is a molecule discovered centuries ago, if not decades, if I'm not mistaken. And then talk about access to statins or second line antihypertensives or simple antidepressant medication. Access to this on the right is one of the papers we published from a district in southern Karnataka, where still we are struggling with access to essential medicines to be made available in a meaningful way at sub-centers and primary health centers. We are still struggling also with the access to emergency obstetric care, neonatal care, essential laboratory conditions. So we still have this entire unfinished agenda which the public health system is grappling with, it's struggling with, and there's very important reforms happening in order to distribute this in a more equitable fashion. Next slide. And the reason to again bring this up is not to say that rare diseases are now in competition with anemia and malnutrition, but to realize that if and when rare diseases are occurring in populations which are already socially disadvantaged, that is a staggering burden. And currently, as you know, we do not even know what is that burden, more so among rural, Adiwasi, and various other socially disadvantaged communities, because it's a problem that we are not quantifying at all. So it's an unknown currently. And what public health tells us is that these communities are probably going to be much more having an aggravated manifestation, chronicity, morbidity, and mortality, because they already have the disadvantage of anemia, malnutrition, and various other more widely prevalent public health problems. Next slide. Another example of this is, for example, the Adiwaji population and sickle cell disease. Yeah, so you have, for example, slightly more privileged communities who are able to better advocate in urban areas for rare diseases, and they're able to form these patient groups, etc. But you also have large numbers of socially disadvantaged communities who are not able to organize in a meaningful way and advocate for their rights and obtain these things. So one of the ways I posit that we can try and address this is by looking at this as not as a healthcare delivery issue, but as a systemic issue. So and this we have, and there are various frameworks. I will not bother trying to explain this. For example, is one framework on looking at health in a systemic lens, which talks about health and healthcare as an output of a complex interaction between various components, most importantly including leadership and governance, which too ought to happen in a very decentralized way. As you all know, in the hundreds of districts in India, there is a very strong district administration, and districts vary one to another, and implementing national policies without change or adaptation and in these 600 odd districts is going to be a big challenge if we do not empower districts to be able to function and govern their health care and health services in a much more decentralized way. Next slide. So one example we tried in this recent publication on sickle cell disease, which is heavily prevalent among many Adiwasi communities, but also among many Dalit communities, for example, is to try and locate the patient or the individual who is having a given disease within the wider system. I mean, without going into all of these different elements which have an impact on the individual life course, I point, for example, on the left side, what is often gets hidden in this idea of context, where the political context. Many Adivasi communities, for example, are struggling with unfinished agendas related to forest rights, land, livelihoods, employment, etc. So addressing sickle cell anemia among Adivasi communities will then not only require diagnostics and gene therapy and new innovations, but will also require addressing support groups, for example, providing culturally appropriate clinical care in Adivasi settings. And a lot of these will have to happen at the local district level. It will have to happen through, for example, setting up registries which are located in local medical colleges. It will require panchayats, for example, to also enter into the agenda of rare disease. So there's a lot of, I mean, while I completely understand the challenges related to diagnostics, therapeutics, and the science component, there's a huge society component there, which requires social science engagement, which requires participatory research, and which requires practice communities, clinical, nursing, and various other practice communities to form in order to address this. So it's a very complex topic, and I know I've opened up a lot of boxes, but given that I've already, I think, overshot my time, we'll go to the last slide. And I hope we can try and address some of these debates in our interaction and try to see how to widen or expand the agenda of rare disease within the public health community as well. The next slide, please. Yeah, so and thanks very much. And I'll take a few seconds to point out that we are setting up with as a DBT Wellcome Trust India Alliance Center for Training, Research and Innovation in Tribal Health, where along with a speaker from the next webinar, Dr. Deepa Bhatt, we are setting up a registry, probably the first ever in Karnataka at the Government Medical College for sickle cell disease and 2 other hemoglobinopathies as one of the efforts at trying to address these among Adiwasi populations. Thanks a lot, and back to the organizers.
Thank you, Dr. Prashant Srinivas. That was quite insightful and interesting to know that you are setting up a registry with, where Dr. Deepa Bhatt is involved, who would be a panelist in the next session. So we look forward to more insights on this. We move on to our next speaker, Dr. Arun Singh. Dr. Arun Singh is currently a professor of neonatology at AIIMS Jodhpur, and he is also the National Advisor for the National Child Health Program Rashtriya Bal Suraksha Karyakram for the Ministry of Health and Family Welfare, Government of India. In addition to this role, he is also the advisor to the Chief Minister of Andhra Pradesh on mother-child health. He has played a critical role in the design and development of several child health concepts that were adopted by the Government of India. For example, he developed the concept of sick newborn care units and also developed the design for the modern labor rooms. He is also a professor and former head of the Department of Neonatology at Institute of Postgraduate Medical Education and Research and SSMKM hospitals. So Dr. Singh, we invite you for your talk.
Thank you very much. And is it visible? One second.
Yes, it's visible. Yeah.
Just let me take to the person. So before I get distracted with these slides, this is something which I would like to say up to the discussion. So when we talk of rare disease, and rare disease has always been a debate, what would you call, what would be the prevalence? There are countries which say that 1 in 1,000, any disease which is more than 1 in 1,000 should be included in rare disease. In India, we also had this problem that if some of the issues are already being addressed, should it be included in the rare disease or not? But let me tell you, if we want to take the first step in this country of talking of rare disease, one of the essentialities which come out, that whatever may be the therapy, if a rare disease, if a genetic problem or some problem has occurred in a newborn, there is no debate that early screening and diagnosis would give you better results. So the same problem, if discovered by the parents, let's say 2 years later, 3 years later, it becomes difficult. I know some of the rare diseases may not manifest in the newborn period, they manifest later on. So at least up to the age of 6 years, there should be screening. Now, when we talk of screening, we talk of a Western model of screening. So someone is interested, let's say, in muscle disorders. So they would say, okay, we set up and we start screening for muscle disorders. Now, for a moment, I would ask all the audience to think, if you are a parent of a child and one group came and said, we want to screen for muscle disorders, early muscle disorders, because of course, when it is very imminent, then the parents will bring the case to you. So they say, okay, they invite you to the home, you go through it. You may or may not find someone. The next day, another person comes and say, well, I'm interested in rare diseases of hearing related to hearing ability. So I'm going to test your child for hearing. The third day, someone would come. I'm interested in homocystinuria, which may affect the vision. So I'm interested in that. Now, after a point of time, you just can't go on screening for each and every rare disease. So we came to an understanding that screening has to be comprehensive. Screening has to be done by a generalist. Management has to be done by a specialist. We can't create a system in which, since I'm interested in, let's say, in Down syndrome or in some other syndrome, I will screen only for that, collect the data for that. That forms a good paper, but that is not feasible in a country, even with countries with lower population, forget when we have a population of 1.4 billion. So the point which I'm quickly trying to make, number one challenge is you need to screen. And when you screen every child which doesn't look to be a normal. There are a lot of times when it is very difficult to assign a particular disease because it's a developing brain. There are a lot of metabolism which has not been tested. So you have to wait. But if you can understand that this child is deviating from the normal, then that child should be under the radar so that A, the main diagnosis can be made, and B, the investigations can be carried out. And if some management is already existing, which is good, it can be done. The simplest mechanism, I would say, congenital hypothyroidism. Now, some of you may include it in rare disease or not, but let's understand that congenital hypothyroidism is 1 in 1,200. When ICMR did a study at 5 places for all newborns, the debate was, should we wait for the symptoms to appear and then screen, or should we do a universal screening? And it was found that by the time you allow the symptoms to come, what we are classically taught as clinical features of hypothyroidism, and by the time the parents think that there's some problem with my child, you can still treat the child, but the cognition which you have lost can never return back.
Hi, sorry, Dr. Singh, for the intervention. Are the slides like moving? Are you moving the slides, or we are on the first slide?
We are on the first slide.
Okay, sorry.
So I'll just complete it quickly. So before I move on. So my first challenge, as I said, was in case of congenital hypothyroidism, by the time you do selective screening, that means children have some feature and then they come to a doctor and then you screen, you have lost the IQ points, which with whatever treatment, you are not going to get back. So that child will remain handicapped. So with the best of the effort, he will improve, but will not become a normal child. But if the same child could be screened at birth, that child would be like you and me. And that's very important for any Homo sapien, because cognition is very important for a family, for a society, and for a country. The next thing is, okay, now we screen. The second $1 million question is, who confirms it? Where does it get confirmed? And the third is, where will it be managed? And even if there is, let's say, a management which is still not, the government cannot claim that this is a standard of management, but there's some hope to the parent. It is still a trial medicine. Can it be allowed? It's very costly. Now, all these are very important for the parent. That child is very important, and he's wanting to give it a trial with a medicine which is still not the standard care. For the government, it is very difficult if something goes wrong, how to defend it, whether that. But We were just talking of screening for sickle cell anemia. Now here I have a question. Why do we want to not screen for entire hemoglobinopathies of newborn? People have questioned that it's not possible to screen for thalassemia in a newborn, especially for trait. It is possible. And there are countries which are doing it. They call it screening for hemoglobinopathies, because in Bengal, in Bihar, in Odisha, there could be a combination of one parent having beta thalassemia, the other having thalassemia E, but the combination would be a major disease, though you could argue that only one parent had beta thalassemia, so why should the child present features of major thalassemia? So what I'm trying to say, individually, these hemoglobinopathies may act. So tomorrow, there's a paper which shows that there's a population which may have both one parent is sickle and one parent is thalassemia carrier. So this combinations is going to occur as our society is going to mix up further. This thinking that sickle cell only remains in tribals could be partially correct at a particular time, but may not be correct in the longer picture. Hence, the Rbsk program, which in 2012 was called to develop it, thought that why don't we first and foremost screen every child who is born in this country with simple tools, and that screening must be done by a generalist. That means even a nurse can screen. So one, I will take you very quickly to this journey of the comprehensive screening, which basically the whole Rbsk sees any child with any problem, either it relates to defect at birth or it is some deficiency. Remember, some deficiencies can also present as rare diseases, or it is a disease per se, or there is a developmental delay and disability. So the 4 Ds. And what the learning was that in some of the countries, they screen only at birth. In some countries, they did prenatal screening. But if you want to know the burden of the rare diseases, then your screening must start from the antenatal period till 6 years. Because this slide shows you that if you're only going to screen in the first week, you're going to pick up only 60% of the major birth defects. Some of them could be rare diseases. So it's about 3%, but it could be more depending upon places. Now, India is not a country, it is a subcontinent. So there would be places where one particular disorder may be far more as compared to the other. So that diversity has to be kept in mind, and the screening program has to change depending upon what is it that would be commoner even among the rare diseases, and where we have a treatment which exists and can be given early. So this is the program which right now the government wants to envisage, that all newborn at delivery point, you screen. Now, if you have no money, at least do a visible screening from head to toe. If you have still some money, do a visible screening, do a vision screening, do a hearing screening, do a heart screening. Now, combination of this could come in various syndromes. If you still have more money, take a drop of blood, do a metabolic screening, and in metabolic, the first preference should be for hemoglobinopathies, and then the inborn error of metabolism, the commonest one being congenital hypothyroidism and congenital adrenal hyperplasia. Supposing you still miss it, the child behaved absolutely normal, the next screening is from birth to 6 weeks, that is by the ASHA. And we have developed a very simple picture that you understand whether the child is behaving normally or not. We don't want a label from ASHA. It's just that this child looks different. Then there's a dedicated team from 6 weeks to 6 years, which is known as the Rbsk mobile health team, which is supposed to go to every Anganwadi center. And in each block, there are a 4-member team of 2. This is for the first time anywhere in the world you had such a comprehensive program that at various levels of screening, and you had a dedicated mobile health team, which we did not use the resources of a specialist doctor. We allowed the screening to be done by doctors who would who are not supposed to manage. So we removed the dentist from there, and we said the dental screening can be done by a generalist. So, and once it is screened, it will go to a center known as the Early Intervention Center, which is linked to the newborn care, and in a moment, and then all the interventions, whether surgical, medical, or therapeutic, will be done free of cost. And each state, each district can decide on the priority to which it is done. So now this definition, nowhere in so the world doesn't see it this way. In fact, the visible birth defect are sometimes known as congenital anomalies. So we simplified it. We didn't follow the Western world. We simplified it that any defect at birth, which may present at birth or which is related to birth but comes later on, will be a birth defect. And this could be visible, that is what you can see, like clubfoot, like etc. You can do the functional, you do the screening for vision, hearing, and heart disease. There's a metabolic, you take a drop of blood, you send it for IEM, routine screening, specialized screening like tandem mass spectrometry and GCMS, or a neurological screening where you find that the child is not behaving normally. So these, the 4 parameters totally make a birth defect. And even if that defect comes later on, that should be added in the registry when the child was born and the state and the district to which that birth belonged, so that we have a denominator. So many children were born, let's say 5 years back, but this child, though diagnosed later, the data should go to that particular year where he was there. So this is the visible, the functional, the metabolic, the chromosomal, and the neuromotor, and how we are going to do. Now, I will not take you much time, but as I told you, it all depends. The visible birth defect is something which can be done at 0 cost just by giving a training, which is a 1.5-day training. So one may argue, am I going to pick up myopathies? Yes, you're going to pick up myopathies even by this method, because we have multiple levels of screening. If there's some myopathies which can be very visible in terms of movements right at the birth, some you are going to examine if it is related, some you are going to take the blood. You can even keep the blood for later on, more studies, research, and the neurodevelopment. So how will the process flow? At every delivery point, you train a nurse, and that training can be given at least with a pictorial tool she can record. So there's a software. So in a good centers, all medical colleges, all delivery points where you restate the child, you wash your hands and do the screening. And if you have further equipments for functional screening, nowadays very simple equipments for hearing and vision is there. I'm not saying that you will come to a diagnosis of a rare disease, but at least in your radar, you will have children who are not behaving in the normal way. So most likely all your diagnoses are going to come from this group. So these are the instruments which we are supporting through Rbsk, and this is being given to every district and even a sub-district if a state would like to. So you have an automated bearer which can be operated by a nurse. You don't require a specialized training. Just to tell you, for congenital heart disease, Kerala, they did it wonderfully. Kerala IMR in 2001 was 11, and in 2017, after 17 years, was still hovering around 10 and 11. The biggest debate is how could Kerala bring its IMR to a single digit? That means you had to do more than what you were doing. And one of the ways in which their health minister and the health secretary agreed, because I was a part of that discussion, that we are going to screen, not only screen, there should be a software which should tell me that this is a serious child who has been screened in some tribal area, so we can arrange the movement of the child and the child survives. See the beauty. Today, in 2022, their IMR has come down. What didn't come down for 17 years has now 7.5. So it shows that even from a public health approach, it's not only a human care, and people only talk of statistics. It's statistically possible if we do a good job to bring down the mortality rate. Yes, what they did is the screening was linked with management. So these are just the tools. Now this is the posture. And you can see the posture contains head and spine, eyes, ears, mouth, and lips. So we are not putting a diagnosis. We are not saying, okay, this is anything. So you may have a clubfoot with a myopathy, but that is later on. At least that child should be screened and should be sent to some place. So screening is very essential when we talk, and screening should be universal. You are not screening for rare diseases. You are screening for anything which looks not normal. And then among that, you keep on your spending it. So at least yeah. So now the question was that when you are screening it, which one requires urgent attention? So we divided our screening into those which requires urgent attention within 24 hours, those which require attention in 7 days, and those. So we divided the whole thing by color coding them: urgent, semi-urgent, and routine, and this. Now there was when we were students, we didn't have an atlas. So this atlas of the birth defects was there. And this atlas, the pictures will come from whosoever contributing from our own country. So there could be some which the atlas does not contain, but this can be added. So we shared it with all the states and we said, this is just a baseline. If you are having more of these problems, why don't you put it up? Because that would be very interesting, and that would be. So then there are forms, how to capture the eye problems, and how to screen them, the ear problems, and then you have the heart problems, the neurological problems, and then you say, okay, I would like to do a karyotyping, I would like to do something more. You at least come to a point where you justify that that money which is spent is actually going to relate, and you have a clinical picture. Often when you talk to, in Bangalore, you talk to Dr. Rita Christopher, is now retired, she would always say, where is the clinical picture? How did the child present at birth? You are giving me a blood, I'm getting a metabolic problem, or I did a gene study, there's a gene for a defect. Now here I would like to be very, very important. A lot of doctors are making their diagnosis based on genotype, because now it is easy by spending money to get a microarray. I would say that the phenotype is equally important. I may have a gene for a particular disorder, autism. That doesn't mean I have autism till the phenotype is presenting with autism. So sometimes genotypic. So the phenotype needs to be documented, and there is a value for it. We can't have genotypic screening for the gene screening for everyone. But if I know the association between a particular feature, then I can utilize this tool by looking. That's what is clinical science, or what we call the observational science, which needs to be linked. So here comes the blood. And in Kerala also, they are doing the blood spots, and this blood spots. So you can do GCMS, you can do TMS, you can form a group on a drop. Now, I had a question. Why can't hemoglobinopathy is done from one of the samples of this? From the same sample in which congenital hypothyroidism is picked. This will add a value, because at least even if I can diagnose a sickle cell anemia at birth, I can change I can give him prophylaxis better. Even if I can arrange for a BMT, the cost will be much easier before a phenotypic defect has come. So when they started screening it, I'm just going to show you district-wise Kerala's picture, how every day live they had, how many children born, how many children screened for positivity. And the red ones were which were urgently, the semi-urgent, routine, and warning, and this is there, and the appropriate referral. Now, once after the newborn, they can still have to be screening. So we decided 30, now it has come up to 60. Each state can change, so it has again a problem. And once you have screened, then there is something in the government sector. So I'll just very quickly take you to a center which was developed in Noida, a super specialty government hospital. When we asked the space to the director, kindly give us a space, we are going to design an early intervention center where any such child which has a problem be brought. The answer, he said, I have no space. Later on, since it was a government sector, he gave a space which was parents' waiting space, that too on a 3rd floor with a very narrow staircase. Now I'm going to give you the picture of that.
Dr. Singh, sorry for the intervention. We are losing on time here. Could you please wrap up if possible?
So I think we stop here and you can see the pictures later. Carry on. But
Right.
before I close, there are three things which I would say. In India, rare diseases have to be understood that we may not understand the pathophysiology, but we are creating our own problems. You see, there's hardly any regulation on infertility. The IVF has come up in a big way. All Cochrane reviews are showing that, and it makes sense, that there are more diseases, metabolic diseases, etc., chromosomal diseases in the IVF. Now you see, we have tweaked even the infertility definition. So this is a public health. If people are listening to me, please put up this. When we were students, if a girl was married and did not have a child for at least 5 years, then it was said as infertility. Now that definition has been changed to 1 year. When I questioned WHO, that 1 year means how many people, if they try for a child, they know about ovulation. What is the percentage which will conceive in the first year? The answer is 80 to 85%. Now 15% of children, 15% of women, sorry, are being labeled as infertile, and they visit a doctor. They are given drugs which increase ovulation. That's going against the science. Had nothing been done, they would have waited for 1 more year. Statistics shows that at least 50% of them would have conceived by its own. The same thing is during delivery. We are rushing through deliveries. What was supposed to be taken in 24 hours, we are rushing to it without understanding the problems. We want quick deliveries. We are questioning the nature, that nature is a big fool, that for 40 centimeter distance, it wants to cover more than 24 hours. This approach is creating problems and then trying to solve. So while on one side, we have to solve the problems, we have to also change ourselves to what is known, follow the nature, and try to prevent. If a mother and child is brought together, a lot of problems can be there. So there's less time to explain. But for a common man, I would say we need to ponder that with our resources in such a huge country, can we do something to prevent a rare disease? At least if we don't know, follow the norms which are closer to nature, more scientific, rather than using technology to rush and trying to change. Thank you very much.
Thank you, Dr. Singh. That was quite enlightening and thought-provoking, actually. The last message that you said, follow the norms that are more scientific, is actually very, very important. And your message also on like the case study that you gave on Kerala, with leading to reduced infant mortality rate. It's actually an example that other states can actually also learn in India. Moving on quickly to our next speaker, Dr. Ratna Devi. Just quickly giving a brief bio about Dr. Devi, Dr. Ratna Devi. Dr. Ratna Devi has over 30 years of experience as a medical doctor, public health and management professional working to improve health outcomes in India. She is the chair of International Alliance of Patients Organizations, a global alliance that promotes patient-centered healthcare. Dr. Devi is also the CEO and co-founder of Daksham A Health and Education, an organization that is dedicated to working for access to health, patient education, and advocacy. She also holds the expert position among the panel of experts at WHO Collaborative Global Network for Rare Diseases, among other several offices that she holds. So great. We welcome Dr. Ratna Devi, and the floor is yours. Thank you.
Thank you. Thank you for giving me the opportunity. Thank you to the organizers for allowing me to speak on a topic that is very close to my heart. As has been said already, I am a doctor by profession, trained in public health, but today I will be wearing the hat of a patient representative and a patient advocate, and speaking on equity in representation of rare diseases in public health agenda from the lens of the patients and the patient groups that are working in our country. So moving forward. So I do not have any declaration of interest, and some of those positions have already been, given in my introduction. I would just like to highlight a little bit that a lot of my work is with WHO, not only for rare diseases, but also for non-communicable diseases. And some of the work that I do in non-communicable diseases is far more advanced than the work that I do in rare diseases. And the expression of the lived experience and the involvement of people with lived experience in non-communicable diseases is far more advanced because there is more representation in that particular area. Not to say that the representation in rare diseases is less, but it is just picking up now, and there needs to be a lot more work done. And hopefully in countries like ours, where the representation of the voice is not as defined or as structured as it is in some of the developed countries and some of the more advanced countries or economies, hopefully in the future that representation will become much better. So I would just like to start with a quote which says, "When health is concerned, equity is a matter of life and death." So we cannot talk about equity without talking about a fundamental right to health and also the difference that it makes in a person living or dying. And this is a quote that I picked up from the former WHO Director General, Dr. Margaret Chan. In the beginning of this panel discussion, we heard that in public health agenda talks of health for all in a culturally appropriate manner, which is acceptable to people. I would just change that definition a little bit and say that it is not just health for all, but health in all. Health for all means that there is a top-down mechanism where somebody at the policy level is trying to decide who deserves what and how it is delivered. But health in all means that irrespective of where you are and what your condition is, it is available to you beyond the realm of health. So a person is not a sum total of his disease and the treatment that is available. A person is a human being, and a human being lives and breathes. So it is not just about reaching a hospital and getting a diagnosis or getting a treatment. It is about living in your environment. It is about living in your house. It is about going to school for a child. It is about going to a workplace for a person who has lived through that particular condition. And when we talk of public health, are we really looking at it from the lens of health in all? I don't think so. So equity is the absence of avoidable, unfair, or remedial differences among groups of people, whether these groups are defined socially, economically, demographically, or geographically, or by other means of stratification. And health equity also means that everyone has a fair opportunity to live a long and healthy life. And a fair opportunity to live a long and healthy life means that you look at health or public health beyond the lens of just healthcare, but as a societal well-being in all. And these are some of the structures that we think, that I think should be looked at for improving health equity, which is building infrastructure to support health equity. And this is not just hospitals and diagnostic centers. Address the multiple determinants of health, and this was already alluded to by some of the previous speakers. Eliminate racism and other forms of oppression, and these are some of the social determinants that were alluded to again. And partner with the community to improve health equity, which means listening to the lived experience, not only in terms of access to diagnosis, treatment, etc., but also other parameters that help them to access these services, and make health equity a strategic priority, which currently is not the case. So my topic today is rare diseases, disadvantaged and left out. And I have very thoughtfully put this heading to my slide, because as we said, it is difficult to diagnose. So even if we do have a diagnosis, do we have the means for the patients to reach the diagnostic centers, to be able to wait with dignity and then access that diagnosis? So when we talk of lack of access, it's not just about paying for that diagnosis, but being able to understand that there is a diagnostic facility available for that particular condition, having that awareness that going to that diagnostic center might help them to be able to reach some kind of decision making, and then reach that diagnostic center from maybe a rural area or from a tier 1, a tier 2, or a tier 3 city, and then be able to wait in that that. So just to give you an example, if a child is on a BiPAP machine or on a wheelchair, is that diagnostic center wheelchair accessible, or does it have the facility for a person who is not able to sit or stand to be able to wait there? I don't think we think about all these things at all when we talk of difficulty in diagnosis. Similarly, difficult to treat. Do people have enough information about where these treatment facilities are available? And if we look at the National Public Health Agenda, then we do have a national policy for rare diseases, and we do have centers of excellence, but how many people actually know about this? Even if you went to the public health community, the doctors, I don't think medical colleges actually talk about this, or this is discussed beyond the clinicians. The clinicians are the one who are aware of this, but within the medical fraternity itself, or even the paramedical staff, this information is not available. So do we need a public health campaign that will actually percolate this information to not only the general public, but also to the experts who are able to treat or able to at least give the advice for treatment or follow-up for the people who need these kind of services. We also talked about lack of scientific knowledge. Again, this is a sum total of several factors. There is lack of investment, there is lack of motivation, there is lack of several other factors. And because this scientific knowledge is so restricted, a lot of the evidence that is generated for rare diseases is carried forward from Western medicine. And we do not have our own epidemiological studies or our own databases to be able to understand what our populations are going through and what is really affecting them. How can we do this? And somebody did talk about digital, and digital is now exploding in the rest of the world as well as in India. Mobile phone access is very high in our country, but are we using this to the advantage of the patient populations? Are we sending simple messages to them saying, hey, if you have this, maybe you need to go to your nearest doctor and have a discussion with that person? I don't think we are doing this, and this is because everything works in silos in our country. There is no integrated approach as far as rare diseases is concerned, and rare diseases is still seen as a vertical silo. It is not integrated into the public health system. And then, of course, the difficulty to treat because of multidisciplinary teams that are needed. Most hospitals are in cities that are either in tier 1 or metropolitan, and therefore the ability for patients and families to travel and spend long amounts of time or multiple visits is almost impossible. So there is no mechanism to be able to motivate those patients to come to this. And having worked in, say, National Vector-Borne Disease Program, where this ability to be able to support transportation of patients, transform the ability of people to come to these centers, maybe some of those lessons that are already there in other public health programs in the country can be taken as examples that can then lead to better access for patients with rare diseases. So if you can do it for malaria, if you can do it for tuberculosis, if you can do it for Kala-Azar, why can't we do it for rare diseases and help people to reach the centers for treatment as well as for diagnosis? Again, difficult to manage, and there are several social consequences. As I said, when I work with patient groups, we get SOS calls from even big cities like, say, Chennai and Hyderabad, etc., saying, we are not able to get the treatment here. Can we come to Delhi, or can we come to the All India Institute of Medical Sciences? Because these are seen as beacons of hope, where there are people who have the ability to treat the most difficult of rare diseases. And when we try and contact these clinicians, most of them are extremely supportive, but then the infrastructure to be able to manage this large burden does not exist. One AIMS in New Delhi cannot treat all the people in the country. We need more such dedicated clinicians and physicians who are able to offer that expertise in the rest of the country. And most importantly, difficult to pay for treatment and life support. So it's not just the treatment when they reach the hospital, but most of these rare diseases also need life support even when they are within their homes. And there are no medicines or the medicines that are available are extremely high cost. So again, when we talk of health in all, we are talking of regulatory reliance. We are talking of how can we get medicines that are already available beyond the borders of this country to be registered with ease. How can we get these medicines to be available to populations? So there are many, many treatments, especially gene and cell therapy, which are currently not available in our country. Patient groups are very amalgamated. They are part of the national and international alliances and coalitions, and they hear that there are treatments and other modalities in other parts of the world, but they are not there, and that gives them a lot of frustration. So when we talk of public health, how can we get this information that's already available without reinventing the wheel? And most importantly, quality of life is not a priority. So when we talk of public health, we are not even thinking of quality of life parameters or indicators or how we measure them. Some initiatives for promoting equity for rare diseases. Are we really talking of universal healthcare and the Sustainable Development Goals 2030 agenda when we talk of rare diseases? I don't think so, because people talk of millions. We say 70 million or 90 million rare disease patients, and it is very expensive. So when you talk to policymakers, you can hear the wheels turning in their heads, 70 million into so many crores, and we don't have the money. But look at it from the lens of, say, non-communicable diseases. So when you have 25 million diabetics or 70 million hypertensives, we don't say all of them are going to need a bypass surgery, or all of them are going to end up with a stroke and will need some kind of mechanical thrombectomy, which is very, very expensive. You talk of prevention and you talk it at the baseline or the grassroots. Why can't we look at rare diseases from the universal healthcare agenda and start talking about how can we use the resources that we already have to the best use, instead of saying, no, this is something that is very expensive and we cannot really look at it from a public health lens. A lot of discussion has already happened on research and data collection, and we do know that there was a registry that was initiated a few years back that has not really seen much traction. I heard about Kerala doing something. I really hope that this becomes a reality and that we have the evidence and the epidemiology to be able to make some quick decisions. And then promoting equity in care. So when we talk of several public health problems like, say, HIV, the community came together to be able to discuss and dialogue with policymakers, saying if we make a referral, they have to be given special attention. Can the patient community in rare diseases come together and work out some kind of a system where we say, if we refer a patient to a particular center, can our referral be given some kind of priority so that that person gets attention instead of waiting in long lines? And when we talk of equity, we also know that most of healthcare, especially the indoor, happens within the private sector where people have to pay out of pocket. How can we then promote equity in the private sector? Can there be a public-private partnership model where private sector is invited to partner with the government so that a little bit of access difficulty is eased and the burden of accessing healthcare becomes a little lesser for the rare disease community? And then, of course, increasing healthcare workforce diversity. This has been a problem from the public health lens for all diseases, not just rare diseases. We are very, very clinician-centric, and we don't like to move the needle of power from the clinician to the other healthcare specialties, or even develop those alternate roles and responsibilities. We do not have anything that goes beyond just the doctor, physician, or the nurse, the pharmacist, etc. We need to develop alternate healthcare workforce so that the large population of rare disease patients are able to access healthcare without really waiting for a doctor's appointment. And then most importantly, influencing the determinants of health and voicing and modeling commitment to health equity. So having a national policy for rare diseases which does not have any outlay for finance is not going to help the rare disease community unless there is some you have to put the money where the promise is. So unless there is some kind of ability to pay for most of these rare diseases, it is going to be extremely difficult for the rare disease community to have any hope in the future. So that was the last part of my slide. I tried to restrict, but I still have gone beyond time. So thank you so much for giving the opportunity once again.
Thank you, ma'am. You were actually within your time schedule, but it was definitely very enlightening talk that you gave, especially the equity of rare disorders, which is something which the policymakers have to finally take a call. Where do we stand today, right? And moving forward. So yes, it was very, very interesting, and I'm sure the audience did like that as well. So thank you so much for your talk. Now we move on to the last panelist, who is an industry expert. Dr. Narendra Chirmule. He is the CEO of Symphony Tech Biologics and former head of R&D Biocon. Dr. Chirmule is the co-founder and CEO of Symphony Tech Biologics, a data analytics company focused on engineering solutions to biology. Also, he's a former head of R&D at Biocon Bangalore. He has held leadership positions in Amgen and Merck Vaccines, two biopharmaceuticals. Dr. Chirmule is also on the NIH Advisory Committee for HIV vaccines. He's a TEDx speaker and has recently published a book, Good Genes Gone Bad by Penguin Press, both of which describe lessons learned from colossal failures in drug development. So Dr. Chirmule, the floor is yours. Thank you.
Yeah, thank you so much. I will share my slides. It's been a very enlightening last an hour and a half from all the previous speakers, and I've learned a lot. And I want to especially thank Mahua, who I've been working with for the last 6 months or so, trying to understand the landscape of rare diseases in India. In the interest of time, I'm going to go quickly, and we'll see if we can have more time for panel discussion. So one of the points I wanted to make is that when we compare ourselves in India to let's say, United States or rest of the world, it's great to see this group of people working on rare diseases. Just to put it in perspective, in the United States, the Orphan Drug Act was passed in 1983. So they've had a much longer head start of trying to coordinate everything with rare diseases. So the US law provides 3 incentives. I was asked by Mahua to speak on how the industry, especially in India, sees rare diseases and how drug development decisions are made for rare diseases. So the US law provides 3 incentives, 3 major incentives. One is a 7-year market exclusivity, a tax credit, and an incentive to get research grants for doing clinical studies. With those kind of incentives, just as a perspective, there are almost 700 odd requests for rare disease applications every year in the United States. So 700 companies, at least 700 drugs are being requested to be developed every year. That's a very large amount for the last several decades now. And this slide just shows an example of the kind of companies that are working, small and large, on orphan drug rare diseases. If you look at the list of all the drugs that are published, but that are approved by the FDA every year, I can make a very long list. I will leave these 5 drugs that were approved last year. Remember, despite COVID, these 5 drugs were approved last year for rare diseases. The worldwide sales for rare diseases by 2024 is anticipated to be somewhere in the $200 billion. The last one, for example, hemophilia A and B, Hemlibra. I personally, my very dear friend Murli, who has hemophilia, is benefiting enormously from Hemlibra directly. So I have personal contact with someone who's taking drugs, a rare disease drug. So this is my main slide for the presentation. I was asked to speak, what are the incentives for pharmaceutical companies, both here in the United States, to develop drugs for orphan diseases? The first one I can think of is the obvious one, to provide treatment for desperately ill patients. Most times there's very little competition. As I told you before, long patent protection is provided by authorities. Orphan drugs often carry high price tags because of their rare nature and lack of competition. There's a potential to achieve fairly high IRR rates, that is return of investments from rare diseases. And the next one is an interesting one. The orphan disease indication, this is more on the science side, the orphan drug indication provides scientific insight into the mechanism of disease pathogenesis. For example, if there is a drug like IL-4 receptor, which is being used for ultimately treating asthma, before you start developing the drug for asthma, you can test it for another rare lung disease indication like lung inflammation. And if anti-IL-4 antibody has an impact on rare diseases, the likelihood that it will have an impact on asthma also is high. So this is how the development strategy is used in pharmaceutical companies. And finally, faster approval time for the rare disease is a very big incentive. And there is a phenomenon in the US called the Voucher System, which I won't have time today to go over detail, but if there are questions, I can explain that a little bit more in detail. Some interesting facts about rare disease and pharmaceutical companies, and this is from a Harvard Business Review article. Stock prices of companies increased by at least 3.3% after announcement of orphan drug disease approval. And then another one, which is very counterintuitive but true, but through analysis, companies with orphan drug market authorization are more profitable and are more attractive investment opportunities than non-orphan drug companies. And this may have many reasons. The financial one is the obvious one, but the compassion of the company to be able to develop drugs for rare diseases goes a long way in demonstrating that the company really means to build drugs for patients. So I'll stop here. And maybe if there are questions, I can take questions in more detail in lieu of time. So back to you, Anjali.
Thank you, Dr. Chirmale. I think this was the most quick presentation and I think very informative. Thank you so much for keeping within your time limit. Thank you. That was very informative. In the interest of time, I think we will be skipping the open floor discussion among the panelists, and we will be quickly moving on to the Q&A. But before Q&A, we would request Dr. Prashant Srinivas to summarize the discussions of the 4 panelists in your own words, and maybe it would help the audience also to understand in terms of a summary what best we could take it from there for the Q&A. Thank you.
Sure. In the interest of time, and like Dr. Chirmale said, so that we can have some discussion on this, I'll be brief and I will not attempt being too comprehensive. So pardon me if I miss some of the points. So we started with Dr. Dhawan's presentation. Main takeaways: expanding access to clinical trials in the interest of equity and removing policy barriers for that to happen. More collaborative and interdisciplinary thinking. And an important point, although said very briefly, the fact that for universal health coverage to be achieved, so we need to cover rare diseases. She mentioned health insurance, but health insurance is one way, but how do we move towards universal health coverage where rare disease is an important component of UHC? Of course, there was a lot more information on from the perspective of muscular dystrophies also. Then I'll skip mine and I'll come to that at the end. From Dr. Singh, we learned some amazing efforts by the system in the form of the Rbsk program of the Government of India, which has been able to bring in newborn screening that can cover a large spectrum of rare diseases, even if not all. And I think this is commendable because wherever a program works through community health workers like ASHAs, ANMs, etc., it works everywhere in the country because that system touches everyone, most people, let's say, at least. So that was a very important input, and I think Rbsk is a great entry point for the rare disease community to be able to impact very large number of people. And of course, there was a very interesting example of Kerala that he presented. So from that, I again highlight the importance of governance. I think the importance of political, state, and administrative will to implement such a program, I think mattered in securing very good outcomes there. I'm sure. But so that was that. From Dr. Ratna Devi, I really commend the wide systems view, and I think to some extent, because she spoke from the patient perspective, I think she brought in what doctors and scientists importantly miss, because doctors and scientists tend to completely stick to the clinical and medical or the scientific viewpoint, whereas the social consequences, the rural-urban divide, the lack of integration, the lack of focus on quality of life and quality of care, because rare disease is not only about diagnosis and therapeutics, it's also about the quality of life that these people are able to live. And more importantly, the clinician-centric solutions, I think that really touched an important nerve. So when we talk of solutions in public health, we tend to focus it around doctors largely, but sometimes also about nurses. But healthcare, as we know, is much wider than doctors and nurses. And she brought in financing. So that's what I like about her presentation, which covered the system, the rare disease, the entire rare disease health ecosystem. And finally, Dr. Chirmule's important points on how to leverage industry to invest more in rare disease, because this is not only about patients and access, it's also about new therapeutics, new innovations, and new technologies. I've already had enough of my time, so I'll just say my presentation's main message was that equity is more than rich and poor. We'll need to also keep in mind various other axes of inequities, including gender, disability, caste, urban and rural location, and of course, rich and poor. So with this, I hand back to the moderator, and hopefully in the next 15 minutes, we can also try to have some directed interaction and questions. And apologies if I missed something. I was not attempting to be comprehensive.
Oh, no, thank you, Dr. Prashant. That was pretty comprehensive, and it was summarized really, really well. Thank you so much. So as I said, in the interest of time, we are skipping the open floor thematic discussions and we are moving quickly to the Q&A session. I hand over the floor to Mahua now to take the Q&A from the audience, and we can then get it addressed quickly. Thank you.
Thank you, Anjali, and thank you to all the speakers. It was an extremely immersive session, and in interest of time, we have skipped one of the round, but it's fine. We will get the answers to the questions here. So yeah, so I think I'll direct my first question to Dr. Arun. The question is asked by Dr. Sudha Bhattacharya, and Madam is with us. So the question is, how was your screening program helped to increase? How have your screening program helped to increase the diagnosis of rare diseases? Can it be used to obtain an estimate of disease prevalence? Yeah, so, over to Dr.
Yeah. So very correctly, there are two things we need to understand. What is the starting point of a rare disease? See, once the rare disease has been diagnosed, then it is much easier to go about whether the treatment exists, where the treatment exists, where to refer. What should be the starting point? So there are two kinds of broadly groups. One, which is very obvious right at the system, where anyone with some knowledge can diagnose. So this is one group. The second is even for us a diagnostic dilemma. But there is a point here. Even if it is a diagnostic dilemma, that child will not behave like any other child. So will either have some problem in neuromotor, in speech and something. Such children, they are referred to the early intervention center. And if you focus from them, and it may take them some time, so they then can be even the rarest of the rare you can find in that group. So the screening definitely tells you two things. One, what you could not diagnose, but the child appeared to be not behaving their normal. And one, there is a straightforward diagnosis. But newborn screening is an opportunity which should not be missed, because every child, the parents want to know if my child is normal or not.
Thank you. Thank you, Dr. Arun. That was a very comprehensive and articulate answer. I hope Dr. Sudha has got her answer. Dr. Sudha is one of the leading rare disease advocate and a very eminent scientist. She has another question for Dr. Naren. So I would request our team to kindly give her the mic and so that she can come live and quickly ask a question. So by the time that is done, maybe I'll take another question. That is for Dr. Ratna. This question is from Diksha, and she wants to know how to calculate a rare disease incidence using retrospective data.
Thank you, Mahua. I'm not sure I'm the right person to be answering this question because I don't do research. Maybe you can direct it to somebody who does epidemiological studies.
Okay, so maybe Dr. Prashant, would you like to take this up?
Sorry, could you please repeat, Mahua? I was trying to put.
Yeah, so how to calculate a rare disease incidence using retrospective data?
Maybe I'll combine a bit also the previous question that Dr. Singh already answered, just to supplement that and this question. Retrospective data will have to exist on rare diseases, and routine program data, as many of you will know, is a challenge in India. Health and healthcare, we must remember, is a state subject. So that's also another big barrier for central policy makers, because health and healthcare are organized slightly differently, although there are very important national missions. So routine data, wherever data is good, and if it does capture rare diseases, then it can be used. In Karnataka, I can say among all the rare diseases, I don't think routine health department data captures it. There are expert centers in Bangalore whose routine data might capture it, and in that instance, retrospective data can be used, but it will obviously not give a population level estimate. It will still remain a hospital based estimate, which is a good starting point.
Thank you, Dr. Prashant.
So I answer to this.
Yes, Dr. Arun, please go ahead.
So the point is that if we screen all children, so say a child has been born in a village in Karnataka. Now the rare disease was diagnosed when he is in Delhi. All we require is two data: the year in which he was born and the place in which he is born, because the denominator needs to be the number of children born in that district, not hospital. If I know that in 5 years back, so many children were born in that, then I can of course track. So all you have to do is, whenever you diagnose a disease, go back to his date of birth, go back to the place where he was born and put that data there. So it is a dynamic data, and it will tell you the incidence, because you have a denominator, number of children born and the child. That's
yeah. Thank you, Dr. Arun. So I think Dr. Sudha, you can turn on your video and kindly ask question to Dr. Naren.
Okay, thank you.
Thank you, Dr. Sudha. Yeah, please go ahead and ask your question.
Okay, can you hear me?
Yes, Dr. Sudha, you are perfect.
First of all, I would like to thank all the panelists. This was really very revealing and educational for me, since I've entered this space recently. So Dr. Arun, thanks for answering my question. Actually, my concern was a little bit that, since you're doing this really excellent program, almost like door-to-door survey of, babies who have some feature which sort of stands out. So my idea was that if you can make it a quantitative thing, then, one problem is in rare disease space is that the government always says, where are the people, where is the data? So you are anyway doing it, for your own study, but if it could be made quantitative, then we could also come out with numbers, even if we don't have a diagnosis as such, but we know that these are the potential. Even that, I think, would be a very valuable information and data.
sure.
Dr. Sudha, sorry if Dr. Arun was answering the question.
No, I just said, yeah, that's
okay,
a very
sure.
important point.
Okay, so Dr. Sudha, could you please go ahead with your question to Dr. Naren?
Yeah, Dr. Narendra, thank you very much. So we as rare disease, patients, people suffering from rare disease really look forward to the companies, like Biocon and other very progressive companies to come forward with helping out in developing the technology platforms. Like say if we have a gene therapy or gene editing platform developed in the country, then it can really benefit a large number of patients because it is more like a platform technology. So why is it that we hardly see any such initiative coming from, the pharma companies? I can understand that, there are a lot of initial hitches, but do you think the time is now ripe for pharma companies to somehow be lured into this so that they can join forces with researchers and clinicians to make it possible in India? As you know, the drug pricing is so high that even if a drug is available, we cannot afford it in India. So I would like to know your views in that.
Yeah, thank you. Thank you for the question. I'm going to try to see if I can answer it succinctly, but I'll give you a little bit of a perspective of an answer before I come to answer the rare diseases. And one point I will make, not even rare diseases, just regular novel drugs for large indication diseases are not being developed in India. Very few companies are developing drugs for novel drug discovery, not even rare. So rare to baad mein aayega. So I'll just tell you a little bit of a perspective of why that is the case, right? I think the risk, ability to take risks in India by the pharmaceutical company is very low. So we started off in 2000s by making generic drugs, which is basically drugs that have gone out of patent, and we became really good at it. 40% of the drugs in the world are sold by companies made in India. Then the next decade became the drugs for making biosimilars, which are sort of the generic versions of biologics. And we became, in the next decade, from 2010 to 20, we are now becoming very good at making biologics. Now we will start making novel drugs, because I think now we have become very good at understanding how to make biologics. Now from 2021, we will start making novel molecules. I think rare disease have to wait another 10 years. Hopefully not, but the way I give the analogy is generics. The pharmaceutical industry in India was in elementary school. Biosimilars, we went to, let's say, high school. Now we are in college. PhD to rare disease baad mein hi aayega. College ke baad hi aayega.
So do you think we've now entered college? Have we now entered college?
Baad mein PhD karenge. I'm being a little...
Dr. Narendra, I just had a follow-up question. There are a lot of molecules that can be repurposed. Why is the Indian pharma not looking at repurposing? That is not new molecules.
Well, I think this requires a much more detailed discussion, and maybe I will take the example take the example with you. I know Dr. Arun Singh, Anjali or Mohua. How much time do we have? Because I want to indulge Ratna with a question.
Please go ahead. We'll take the liberty to just extend our time a little bit. Our apologies to the audience, but yeah, please go ahead.
Okay, Ratna. Let's say you own a company. Okay. Developing a drug for a rare disease is going to cost you, let's say, 100 crore. Okay.
I understand the philosophy, sir. I still ask you that question.
I'm going to answer you. You're going to answer your own question in a minute. So you're going to invest 100 crore of your own money or your investors' money and develop the drug, right? For the rare disease, will you invest 100 crore?
No.
They have already have the answer. I was hoping you would say yes, at least at this first question. But if you had said yes.
No, but I have an answer to that, which means there has to be a publicly funded mechanism for it's not an investor money. If it is not an investor money, it has to be some other source that is investing into it. But we cannot say because we don't have the 100 crores, we cannot have an answer to it.
The definition of industry, if you want to pure play definition of industry, it is invest and returns of investment. That is what industry does, right? There's compassion and all that CSR money, all of that we can talk separately. But if you want just pure investment, rare disease, I would rather make a baniya ki dukaan. 5 shop mein zyada paisa mil jayega mujhe, sab paisa hi banana hai to, right? But there has to be passion. And so Ratna, the follow-up question, if you had said yes, was I would have said that you're going to invest 100 crore, but your return is going to be only 1 crore. So will you accept the loss? No pharmaceutical industry will accept this loss unless there is different mechanisms of doing things. What India, I'm talking in generic terms, what India has been very good at over the last 3 decades, I would say, is doing a leapfrog on technologies. We've leapfrogged the phone technology. We've leapfrogged the fintech, the financial technology. Everybody has a UPI on their phone. We've completely bypassed the requirement of everybody having a bank. I think the healthcare sector of giving access to healthcare is going to be that leapfrog. I don't know what that innovation is going to be, but there's definitely going to be a leapfrog.
And why can't we have sub-licensing arrangements or knowledge transfer arrangements? I mean, it works in other sections of healthcare. Why is it not working for rare diseases? Sorry, I'm posing all these questions.
No, I'm happy to discuss. I can give you answers to many of these answers. But Moa and Anjali, do you want us to continue or?
I mean, maybe a quick, just answer to this, and then maybe we'll move towards wrapping up the session.
Okay, licensing, there are many reasons, Ratna. It can't be like one reason, right? Like, let's say, for example, even CAR T cells, let's say CAR T cells, which you probably are familiar with, right? Yeah. In the US, if you get CAR T cell therapy, it will cost you, let's say, $200,000, which is sort of about 1 crore, 2 crore, something like that, right? If, let's say, a company which is selling a drug at 2 crore in the US suddenly starts selling it here for 2 lakhs, right? They will have inequity in explaining to their process, why is it costing 2 lakhs here and 200 crore or 2 crore there? I mean, that is one of the explanations why companies don't come here and have licensing agreements. Let me stop here.
We definitely look forward to having another discussion on innovative financing mechanism for rare disease drugs. If it would have been possible, we would have started right away with all the charged up panelists right at this moment. But in lieu of time, I would like to end the session here. Thank you all the panelists for this extraordinary session, this engaging discussion. And thank you for the enthusiastic participants who have been with us for all this time and for amazing questions, posing amazing questions. We thank Ashoka University, our partner institute, in organizing this event. And this is just the end of day 1. Tomorrow, again, 9:30 a.m., we have another very interesting session waiting for us. That would be on rare disease registry. We would see how to strengthen rare disease registries in India. So I would request all our enthusiastic participants to please join tomorrow again, and we'll have, we can promise we will have another big session.
Right.
Tomorrow.
Yes, sorry.
Yes, Anjali, please join.
Just for the intervention. So I think most of the questions were also pouring in. There were also some for Dr. Jyotsna Dhawan. I think we can take them offline. We can send them over the mail and get them addressed, because I saw on the chat box, there were a lot of questions for Dr. Dhawan. And since it has been there in the question Q&A panel, so why not get it addressed offline through the email mode?
Yes.
Right.
Yes. So questions to thanks Anjali for bringing that up. Questions to other panelists also, we will direct it to them, and we definitely look forward to having answers to all the questions. So thank you, everyone. I would request the panelists to stay back for a group photograph. So please switch on your cameras, everyone, and we'll take a quick photograph. Thank you, all the audience. Looking forward to meeting you tomorrow again. So do we have everyone? I'd request the team to take the pictures. I'd request Dr. Alok Bhattacharya, Professor Shashidhara, Dr. Sudha Bhattacharya to come in as well.
Yeah, I think Dr. Jyotsna Dhawan is
still there. Yeah, Dr. Jyotsna Dhawan, we would kindly request you to kindly switch on your video and okay, let's see. Yeah. So one of our team members, maybe Saikat, can you please start taking the pictures?
Dr. Jyotsna is not here, I suppose.
I think he just left. Yeah, I think we can click the picture because she just left.
Right. Yeah.
Okay. Fine.
Okay. Thank you.
Taken?
Yeah.
Picture taken. Thank you all the panelists again. It was a wonderful, amazing session. Thank you so much.
Thank you so much.
Thank you to the entire team for helping us organizing this.
Yes, thanks to
Dr.
the DST,
Dr. Momita, Saikat. Yeah, thank you, Anjali.
Thank you so much. And we look forward to also having you on board tomorrow. Do attend tomorrow's session, please. Please. Thank you so much.
Thank you. Bye-bye.
Bye-bye.
shall we end up?
Yes.